Good afternoon. Good afternoon, everyone, and welcome to Knowledge Connections. My name is Tom Chow, VP of Research here at Holland Bloorview. Today we're going to hear about the development of a KT Casebook, which aims to shed light upon traditionally difficult conversations about weight and provide resources for making these conversations positive and personally meaningful for clients, families, and clinicians. Based on 7 years of research, which in research years is a very long time, both in Holland Bloorview and beyond, the team has developed an evidence-based practical resource using an innovation framework and extensive stakeholder engagement. Our presenters today are Amy McPherson, a scientist in the Research Institute, Christine Provvidenza, Knowledge Translation Specialist in our Evidence to Care Unit, and Laura Hartman, Postdoctoral Fellow and Research Associate. And also Susan Cosgrove, a family leader who unfortunately can't be with us here today. So I'll hand it over to our team. We're looking forward to your talk.
Okay. Thanks, Tom. And I'm a little croaky, so forgive me if I drink a little water. So Susan, would love to be here today, but unfortunately is stuck at home with chickenpox. So yay for having children. It's going through their entire family. Anyway, so hopefully she's live streaming. Hi, Susan, if you are. Okay, so today I'm going to just set the scene for this casebook, first of all, and it's been built, as Tom said, on sort of several years of research by me, but also other people, and we really wanted to try and put it all into one place. So, I mean, we all know obesity in childhood is prevalent, and that there are some concerning comorbidities that often accompany higher weights. And for that reason, a lot of leading pediatric societies actually recommend that children over 2 have their body mass index monitored. So that's taking their height and their weight and then calculating it and then comparing it with kind of the norms and different trajectories. So they recommend that this is done. However, it doesn't really help if you don't communicate it to the person or their family, depending on how old the child is. And there are no guidelines for doing that, just to how to actually calculate it. So also discussions of healthy lifestyles are also really important. We know healthy behaviours are established early in childhood, and we try and establish them so that they can be taken through life into adulthood. So regardless of weight status, healthy nutrition and physical activity are associated with a wide range of very positive health outcomes. So we're not necessarily tying the two up, but the combination of all those things are important to discuss. And that's in any child. But then in cases where there might be some extra complexities, such as children with disabilities, there may be some additional barriers or issues when healthcare professionals work with them in terms of sort of physical and developmental disabilities. And I know through my research that the topic is often not addressed, and not for the kind of lack of people wanting to, but feeling very awkward. And that's what I'm going to talk to you a little bit now. So, anyone who's lived in Canada or the free world will have seen these kind of images, and we see them every single day. And it's led to a real culture of weight bias and weight-related stigma, which refers to negative beliefs and behaviours directed towards people with obesity. And that wording is important. So many the obesity foundations and associations are now calling for that person-first language and for obesity to be considered as a disease, in an attempt to get away from this weight-based stigma and that it's just a case of eat less, move more, or that it's somehow a moral individual failing. But because that's so integrated into the fabric of our society, we know obesity and higher weights are associated with these negative beliefs, and so healthcare professionals feel very underconfident often to talk about it, worrying that they're going to offend their clients and their families, that somehow they're going to affect their self-esteem, and it's just very difficult to broach it with families, and that's across the board, or kids with and without disabilities. So a rather sobering statistic came from Poole and colleagues in 2013, which was in their survey, 65% of healthcare trainees had heard or witnessed healthcare professionals making negative comments or jokes about people with obesity. So we know it's ingrained everywhere, including healthcare, and that's certainly not every healthcare professional, but I think we just have to be very vigilant about how we talk about these topics. And that's kind of created this perfect storm of it being a very complex topic to think about and talk about. There are a number of reasons that people find, including time and many other sort of structural issues. But as I was mentioning, healthcare professionals report a real concern about damaging relationships and mental health. They feel they don't have enough training, they don't have the time, there are competing priorities, and especially when we talk about kids with disabilities, if they come in for a consultation or a clinic, well, most of you know they have to see the nurse, the pediatrician, the OT, the PT, there are many, many things they come in that need addressing, and so weight often falls down that kind of, but down the priority list for very good, understandable reasons. But that means that many children and families who could potentially benefit from weight counselling and support are not receiving it. So although we're in the situation then, so guidelines on paediatric obesity prevention and management call for all healthcare professionals to be equipped with the skills required to communicate with children, parents and families about weight, but they give no guidance on what that might be. So that's really kind of the background to why I wanted to look at what's the evidence out there. So I conducted a scoping review with a great team of people across the country, really to look at, well, what's the evidence? What are the best practices out there? And we did manage to sort of find, we distilled more as guiding principles rather than best practices. There's very little published information out there, and it's very heterogeneous. So there's many, many different types of methods they use, different people, numbers, there's sort of case studies and RCTs, but everyone's looking at something slightly different. So it was pretty hard to kind of unearth it, but we did come out with these guiding principles that we saw from the literature. And then we did go to families and children and say, this is what we found, what do you think? And got a lot of feedback from them. So that was really helpful about what does this look like in real life? And we've submitted a paper on that as well. So I was talking to Christine one day and I was like, what do I do with all of this stuff? I have all this research. And the more and more I worked, the more I was convinced that really there are guiding principles for all kids and families. There might be some extra considerations for kids with disabilities, for sure, but I don't think some of the guiding principles were that different. So we were racking our brains and trying to think, how could we bring this together? And so we hit upon the idea of developing a knowledge translation casebook. Meant to combine evidence and stories that we heard, excerpts from my research, other people's research, and put them all into one place in a really practical, easy to use resource. So I'm going to hand over to Christine now, who's going to talk to you a little bit about kind of how we developed it and the methods on what these casebooks are, and take you through, give you a sneak peek of some of the casebook.
Thanks, Amy. So before we talk about what a knowledge translation casebook is, let's talk about what we mean by knowledge translation. So knowledge translation, or KT, is really about bridging that gap between what we know and what we do. It's about taking research and putting it into action, taking research and putting it into work. And evidence plays a really critical part of this process. We use evidence to help create our products. We use evidence to help inform how we should share information or how we should implement information, but we also use evidence to help inform the decisions that we make on a day-to-day basis. So a casebook is a type of a knowledge translation product that really does showcase the research evidence in combination with stakeholder experiences and are often used for sharing knowledge and for raising awareness. KT casebooks are meant to be accessible and easy to use with the hope of helping to inform and guide practice. Now, the aims of our casebook are to provide the best available research evidence while highlighting the best available practices when having weight-related conversations, to share the experiences and perspectives of children, youth, families, and healthcare professionals, which we refer to as stories from the floor, and then also to provide some suggestions, tools, resources, and reasoning for our practices when having these kinds of conversations. So we were very lucky that we had an amazing team to work with when putting together this casebook. And truly, this work would not have been possible without the commitment of the following individuals who invested countless hours in helping to build this product. Now, outside of our team, we engaged a variety of different stakeholders representing different disciplines from a number of organizations, not only across our province, but across Canada. And these stakeholders helped to inform the structure of the casebook. They reviewed early drafts and also identified resources that we could incorporate within this casebook. And this process was essential to not only ensuring that our team developed a quality product, but that our product was clinically relevant. Now, as part of our process, we took an integrated knowledge translation approach. And this means that we engaged the users of the casebook to help create it. So we wanted to make sure that everyone's needs, thoughts, feedback were being considered, and that our stakeholders were valued as part of the creation process. This became a co-creation process. We also leveraged different types of evidence by showcasing the current state of the research in conjunction with the experiences of healthcare professionals, families, children, and youth, having them share their perspectives with us, their stories, their thoughts, and their feelings. And then we also took a multimedia approach to creating our product because we wanted to ensure that the different learning needs of our end users were being met. And so in the casebook, we provide text, we provide photographs, we have videos, we have stories, we have case studies. In terms of the development process itself, the casebook creation essentially involved 3 steps. We prepared the evidence, we consulted with stakeholders through workshops, and we engaged in content development and review. The evidence preparation phase involved reviewing research evidence on weight-related conversations within the healthcare context. It involved looking at different tools, techniques that are available to healthcare professionals in undertaking weight-related conversations. We consulted with clinical, research, and community experts and families, as well as youth and advocates who all have experience in this field. And we looked at evidence related to stakeholder engagement strategies. So now I'm going to pass it over to Laura, who in a few minutes is going to talk about how we use an innovation framework from the business sector to inform the development of this casebook. And she's also going to share with you the remaining steps of the casebook development process and provide you with a quick glimpse into the casebook.
Thank you, and I'll just say that for me, I got to learn not only about the topic of weight-related conversations, but also about knowledge translation and creation of knowledge translation products. So this has been huge learning for me, and I hope we can pass some of that learning on to you guys as well. In terms of the innovation framework that we used, it's a 5-step framework that was borrowed from the business sector, and it looks at taking contextual knowledge, taking the information that we have around us, available to us from different formats, so not only research and evidence-based knowledge, but practice evidence, experiential evidence, and bringing all of those together with the group to co-create a product that can help everyone move forward together. So we decided to undertake this approach using 2 workshops in addition to our team's own working time. The first workshop was really to discuss, plan, and design the casebook, so to understand what's out there, what people want, and what we can do to best move the field forward. And workshop 2 was to co-create the actual materials that would be presented through the casebook so that it really is not only co-designed, but co-created to have information in the hands of people, like from clinicians and clients and families to clinicians, clients, and families. So without further ado. Our first workshop started with stage 1, contextual knowledge and information. And this included a topic overview, not only from the team, but for the team. We started by introducing the topic of weight-related conversations as we did today, and then we moved into capturing thoughts, feelings, and hopes regarding weight-related conversations, so that not only are we providing knowledge, but also gaining knowledge of the people in the room, the experts that were invited, so that we can know where they want to go, just like they know where we want to go. And with that, we came together and we discussed our overview of the evidence and best practices in conjunction with the experiences just shared with us. We then moved on to collaborative network of experts and partners coming together to decide what knowledge would be most useful to move forward through this process. We had our collaborators sit together and discuss a number of topics, and at the end of the first workshop, we had a repertoire of ideas of how we wanted to create information and move it forward in the casebook. Our team then took all of this information together and created a number of ways that we could create products at Workshop 2, which, shocking news, is exactly what we did. We were able to bring together the creativity of the people in the room, the knowledge and experience, as well as the evidence that we had presented them, and come together to co-create the products that were available in the casebook. This involved not only creating the products that would be available, but also allowing us to identify products that are already available, but not in the hands of the end consumers as they needed to be. We came together, brought it together, did it all together apparently. I like the word together. But we were able in this one workshop to complete stages 3, 4, and 5 and have this integrated, co-created platform to outline the entire casebook that we would bring forward. Our team then took on the efforts of bringing together the evidence synthesis, so the research, experiential, and contextual evidence, and put together a casebook, which we're going to present today. We then sent it out for content review to provide inclusive perspectives. So we sent it out to families, to clinicians, and to researchers, both within Holland Bloorview and across Canada. We got a number of perspectives. We had a number of mini panic attacks. But we came up with a product that we're very proud of, that we think represents a number of voices in the discussion of weight-related conversations for clinical settings. Pause for effect. And today we present our KT Casebook. So this is just a sneak peek, and it was actually designed especially to be presented today, which is World Obesity Day. We wanted to give everyone a taste of what we'll be presenting later on next month, November 2017. The Casebook is fostering positive weight-related conversations, sharing evidence and stories from the floor through a knowledge translation casebook. It's very nice and fancy sounding, but it's a really practical resource that has a number of advantages. Before we delve into what that is, I want to talk about what guides these conversations. So based on the reviews that Amy was discussing earlier with teams of clinicians, researchers, and families, they came up with a guiding set of 5 questions when discussing weight-related conversations, which are: who should participate in the weight-related discussions? When and how should they take place? What should healthcare professionals say? How can healthcare professionals engage family? And what techniques are recommended? And we thought that this aligned with the conversations that we had during our workshop, so we would also use this framework to guide the casebook. Now, not only is it meant to guide the way that we read the casebook, but it's also a framework to guide the way conversations are had with clinicians. So we tried to make it as practical as possible. We're not just saying, these are the chapters that look really great. This is also all of the pieces that need to come together in order to foster a meaningful conversation. Before we move on, I want you to notice the little purple call out, which is don't forget to ask. Throughout the casebook, we remind clinicians that not every family wants, needs, or is at least ready to have a conversation about their child's weight. And so it's important that before delving into who should be involved, what you should say, what you need to do, you need to make sure that it's the time and place to do so. And if it's not, maybe find out when the appropriate time and place would be. And there are tools to help you find that out in the casebook. Our casebook is also organized on the different types of evidence and tools that we present. So as you can see at the right, there are a number of different icons, and they not only allow you to visually understand what we're presenting in the casebook, so research evidence, stories from the floor, which are case studies, key quotes, and then resources for you to take away, but they serve another purpose. We want this to be a learning tool that you can pick up, you can read all the way through, and you can learn how to foster this conversation. But moving forward, we also want it to be a quick reference. If you want to know what that tool was, you don't have to go through all the pages of the casebook. You look for the icons that you need, and you can have that quick resource to take with you into clinic. So we've tried to design it so that it's very user-friendly and it's appropriate for a clinical setting, which can be quite fast-paced. And we're going to give examples of them right now. So the first is showcasing the evidence. We thought it was important to start with showcasing evidence in a traditional way. We have a lot of traditional professions working with us that are used to receiving evidence in textbook or journal format, written out here like this. So when you see research evidence, it might be easier to initially trust it when it's written in the familiar way. We provide evidence throughout the casebook that is laid out, quoted, in the way that you're used to, in the way that you want it. But we also present evidence in different ways, like this. It's a visual. It's a takeaway that you can not only share with colleagues and quickly reference, but you can also share with families. It discusses who should be involved, how you facilitate a conversation and who should be involved, discussing the roles and considerations for healthcare professionals, families, and children. But importantly, we have children at the center because that's the message of our casebook. It's a visual cue to remember where the children should sit, whether or not they're directly involved in the conversation, depending on age and ability. We have to remember where they are. So we're trying to provide evidence in a number of different ways. In addition to the research evidence, we also have experiential evidence. This, for example, is a story from the floor from Brendan, who is an advocate for the Canadian Obesity Network and who candidly spoke about his experiences in speaking with different professionals about his weight throughout his life. They're positive and they're negative. They're empowering and they're impactful. And we provide these stories so that you know this is what families feel. This is what other clinicians, some of them in the room right now, feel. You're not alone. And together, we can make sure that this feeling is positive and empowering throughout these conversations. In addition, we have quick access resources. So for example, things to think about when you're getting the conversation started. What you should do and what you shouldn't do. Quick reference can be printed and can be kept in front of you. None of them are rocket science, but sometimes we all need a little reminder. But we also have external resources, like infographics on how to conduct motivational interviewing, different apps to help you walk you through the processes if you're not familiar with things like motivational it's a tough one. Motivational interviewing, which is a large part of our technique section. And finally, we have new resources that we've created in conjunction with the people in the room, such as how to use solution-focused coaching in a weight-related conversation. So we bring together a number of different resources, a number of different types of information, a number of different ways of looking at these conversations to drive practice forward. And with that, I'm going to turn it back to Dr. McPherson.
Okay, thanks both. So today is a soft launch. We wanted to time it with World Obesity Day, and as I say, we have shown some of our early slides, but it will all be ready by the end of November, where we'll be doing our main launch at the OCAS conference, and also sort of talking to clinicians there and getting some of their feedback. Hopefully people have been tweeting, hashtag World Obesity Day. Nick's not here, I can normally rely on him to tweet up a storm. It's not designed to be printed out in a typical handbook. It's designed to be online. It's going to be an interactive PDF, so you can jump to things, you can search for things, just as Laura was saying. So we will have it on a website. We have sharing with our networks, social media, as I mentioned. But a really important thing is before it gets released, we have another round of reviewers across, actually internationally, to give us some initial feedback on it before we kind of communicate it to the world. So we will be, keep an eye out, we will be tweeting and launching it probably at the end of November. But what I'm interested to talk a little bit now, and we wanted to leave some time for people to give your views and your thoughts about, so what next? We've made this very nice, very pretty little casebook. We're very proud of it. We're like proud mamas, and our clinical colleagues like it that's been on the team, and parents. But then what do we do with it next? It can't just go onto the internet to die, right? So like so many things. I'm looking at Sean. Yeah, we've had this discussion many times. So what we want to do is go for world domination. And to do that, we want to be doing in a phased approach. So our first phase would be to look for a clinic setting and do some pilot implementation. So find out from clinicians how it's useful, how they used it with people, how do we talk to the parents afterwards, how did you feel about having these discussions, and so on. And then use these key learnings from this for the pilot implementation to inform a large scale. But this is where I want to pick your brain. So as a clinician or in your area of work, and I know not all of you work in this area, but can you see how this might be used in practice, or can you help us understand as well how this could be used in practice to support you having these discussions? This is a sneaky way of just getting your feedback. I can see, so yeah.
Something I'd be interested in using it for is when kids maybe change to a different mode of mobility. So transitioning to a wheelchair, for example, that is sort of a key time when we have those kinds of conversations. So it seems like you've kind of taken a developmental approach. So I think that would be really helpful at looking at different like transitions and stages.
And what's your discipline?
In prosthetics.
In prosthetics. So just for the live streaming system, I was just saying, so in transition periods it might be useful. For example, if a child transitions into a wheelchair, to start having these conversations about how that might impact sort of energy expenditure and things like that. So we should say that this is written for all children, so it's aimed at healthcare professionals, but with all children. But we do have sections at the back about special populations. So we do have a couple of disabilities as exemplars, and we do have some simulations to use, and one of them is showing that exact transition. So how do we start talking about that when mobility changes? What are some other considerations? And when new medications, for example, as well. So when we know there's a side effect of new medications. So, okay, thanks.
Just a question, is it easier to talk about when children are underweight than when they're overweight?
So the question was, is it easier to talk about when they're underweight than overweight? We did have some people question, and we have kept this as solely overweight, so we felt like underweight is probably a whole new different casebook. I think there are complexities with both. I mean, when there's sort of underweight, failure to thrive, often parents are hugely stressed about trying to get enough food into them. I think that brings its own complexities and issues and concerns about rapport with parents and so on. These, hopefully not, Laurie's nodding. Any feeding and swallowing people, I'm thinking of the previous casebook launched. So I think there are differences with both. The issue with overweight is the stigma, weight stigma, and the discrimination that comes with it. Every day at school, in the school playground, when healthcare professionals, very well-meaning, may talk about it in negative terms, or you're just not trying hard enough, or whatever. So I think there's differences there, but the child is always surrounding the child, right? So that can be problematic.
Why would the nutrition plan be although it's a nutrition plan going for underweight children?
So the nutrition clinic is not just for underweight children, and we do refer to it. I think I'm hoping Laurie would agree that it's probably not set up, and the intention is not to treat overweight, is more underweight. Would you say that's fair, Laurie?
I think we get both ends of the scale, and both have their specific issues.
Yes.
The comment. I think with regards to, hopefully, both Joe and I, who were involved with developing this casebook, that we are employing the majority of those resources.
Mm-hmm.
So we can definitely take a look and see if we can use it also in the nutrition. But hopefully, I think maybe Amy's looking at world domination, sort of more wider spectrum.
Yeah. So just again for live streaming, so the comment was that the nutrition clinic here and probably elsewhere in CTCs, I'm sure, see a range and see both ends of the spectrum around weight. So, this could be implemented in it. But what we hear a lot is when it's not a sort of a specialist clinic. So it's the general pediatrician, it's the PT who, people are coming in, this isn't their sort of primary area of work. General nurses in family practices and things like that. So I think it has a range, and so it's going to be really useful, interesting in the implementation is how do we use this resource in different contexts and settings, or how do healthcare professionals use it? Kim?
Yeah, it was just when you started to talk about world domination and spreading it regular clinics and not outside of just within our population, I'm thinking of the RNAO.
Yes.
And their guideline on primary prevention of childhood obesity.
Yeah.
And they're certainly always looking for tools and things that people can pick up and use, and that's a great way to sort of spread it.
Yeah.
More pediatricians and nurse practitioners, clinics, public health.
Yeah. So, we don't want it to stay here. We want it to be used. And the other thing is we didn't want to make it like, oh, this is just what we do. That's why we linked out. We don't want to reinvent the wheel. We've linked to as many resources as we have been able to find and assess, for what we're comfortable linking to. But, this isn't a casebook on motivational interviewing, but here's a link to it. This isn't a casebook on so-and-so, but if you're interested, do more reading, and we do have a link out for a parent resource as well. Kathy.
So Amy, when you're exploring opportunities for pilot, are you thinking about training people to use it? Because I understand this, my clinic, it would be ideal for my clinic because we see a lot of kids with obesity that just, the way the clinics are set up, the first encounter is with the nurse.
Yes.
And so training some of the ambulatory care nurses to be part of the pilot implementation for all the clinics might be.
Well, Marilyn's here, so I'm hoping today to get a commitment that we can train every single nurse in Holland Bloorview. That's right, okay, Marilyn? Yes, and all the nurses in Ontario. Easy.
But I just think because we're first on the scene normally in clinics, and I know our clinics, and I think the population.
Yeah. So the comment was around training. Sorry, Selena.
Is there a training that goes along with this, or is this supposed to be a standalone? You grab it and read it, and then.
So there's a couple of queries there around sort of training and training opportunities. So funnily enough, we were just talking to Darlene this morning about IPE opportunities and how we might implement this with not only students and student health trainees, but also registered professionals as well. So we think there could be a couple of strands there, but for sure nurses, physicians, OTs, PTs, TRs. I think in inpatients is really interesting because every inpatient gets a height and weight and a BMI gets spat out. So again, how do we sort of talk about that? So I think there's a number of ways we could do this, and we are talking this morning about developing a small training resource that would go with this to kind of walk people through it, and then do sessions for people who might be interested. It is designed for people just to pick it up and use it, but I think there could be some training around modules around it that we could usefully do for that.
So you would be collecting information on how it's going, right?
So
that would be the pilot is these people that identified as actually using it and getting feedback from those people and putting it down.
Yeah, so we were getting feedback from the first few people about what's working well, what's not working so well, how did you actually use it in the moment, or if you didn't, then how, that's obviously something we need to look at. So, Lindsay, yeah.
So I just like the idea of it's kind of about lifestyle.
Yes.
And taking it away from being sort of, a medical discussion, more about how you live. And so I like the fit with that, and even in our ambulatory clinics, we're trying to connect participation and inclusion to CDP. So it can't just be something that we do trial on a couple of those, but more towards lifestyle.
Yes.
As opposed to, any kind of illness and, sickness.
Yeah, so linking it is more around healthy lifestyles and maybe using it in a couple of clinics and linking CDP and PNI. So for sure, although it's got a weight-related conversation, it's certainly not all about weight, and weight is only one very small part of health, and there are many, many other ways. So whilst we didn't want to have like a 6-line title to include all the things it talks about. It is very much a lifestyle kind of what makes you feel well. What does that child in front of you need to feel well in their context? As a health psychologist, health promotion is sort of where I come from, so it's very much got that lens.
So would it be appropriate, like for community centers, or like I'm just,
Yeah.
just outside, like if they're having groups, or I see all these empowered kind of girl groups in my neighborhood. and,
Yeah.
like, they, for other reasons, there's all kinds of eating and diet,
Yeah.
but I could just see a helpful resource for them.
So I think we definitely see it as a phased approach and a phased rollout of it, sort of gathering initial information and kind of building and moving forward. But I think it has a lot of applications for sure. So I think that's great. We've written it all down. There will be LOIs submitted to the Centre for Leadership. The slow clap, yeah. So when it's launched, we will be looking for champions as well for sort of disseminating it and pushing it out to your networks, connecting us to any networks who you think might be interested in using it and giving us some feedback of how they've been using it clinically. But I wanted to kind of acknowledge, and then we're going to end on someone else talking rather than me, so we had funding through the Centre for Leadership and Innovation and Child Development, which was absolutely critical for us to put this together. We also had some student facilitators that helped us at workshops, and I think that's really important as well to immerse trainees in this and these discussions as well early on to sort of really feel out how are people talking about things. And it's okay not to know everything, and it's okay to ask and look for resources as well. And we had fantastic workshop participants on our first round of reviewers, and we'll be sending out to a second round reviewers soon, including experts from Canadian Obesity Network on weight bias, to make sure that we're not reinforcing any kind of weight bias throughout this casebook, which is sort of my middle of the night waking up in a cold sweat kind of fear, because we do it unwittingly, right, a lot of the time. So we're trying to just be really mindful of that as well. So, Christine, you're going to do the technical bit. So, although Susan couldn't be here today, sorry, Catherine.
Sorry, one quick question. Amy, you referenced simulations before.
Yeah.
Right? So the simulations that you've developed on having conversations about weight-related issues, are they part of or linked to the casebook?
Yeah. So yeah, a few years ago with Catherine's support, a team of us developed some simulations specifically in the spina bifida clinic because that's our funding, but it's certainly applicable to other settings and rehabilitation settings. So we've sort of been wondering what to do with them for a little while, and this is actually a perfect thing. So we link out to them. We have them on our YouTube channel. Apparently I'm the proud recipient of a YouTube channel, Christine tells me. And linked to DocNet, of course, the Disability and Obesity in Canadian Children Network, and with some guiding questions about sort of how do you think the people feel and what would you do differently and stuff like that. So we've tried to incorporate as many different types of resources as possible for those who are visual learners, who are those who are experiential learners, readers, and sort of trying to match different learning styles. So yes, those simulations are in there. Okay, now I'm going to let Christine, let Susan have the final word, even though she's not here. Okay.
I'm good at building models. Mom here is good at helping me building with my models. And my grandmother is good at keeping me healthy.
When he was a few years younger, because of symptoms of his autism, like irritability and anxiety and things like that, he started on what's called an atypical antipsychotic medication. Right now he's on one called Abilify. And he started at 5 milligrams of Abilify. And the reason for that was things like self-injury, aggression, and anytime you start a medication, you've got to weigh the risk and the benefit. But we did it going to the doctor and talking about what we could do to help with the behavior, and we decided that it was worth the risk of weight gain to try the Abilify. And immediately, he was hungry all the time. His behavior definitely improved, his irritability, his aggression, but with it came the weight gain. So Liam and I went for 2 visits, and we got some good advice from Lori, but he was still gaining weight and still having a really hard time with the craving. So I got to thinking that every day after school, and often a day or 2 a week, he will be at grandma's. My thought then was maybe I needed, now that I had learned what I needed to learn from the dietitian, maybe I needed to pull out a little bit and start sending these 2 as a team.
It was just trying to figure out something that worked, and because I do have Liam very often, he's always come to my house after school, and I was giving him his meals. It was more trying to get everybody on the same page and sharing our information.
Once it clicked that there was a piece of the puzzle missing as far as who was part of the relationship, as soon as that clicked and we brought my mom into the relationship, it really turned around. And it was not just that it was successful, but there was momentum. Like, it was easier, it was more fun, everybody was just rolling along.
We put our heads together how to make it better for Liam, because he was getting frustrated and he was feeling very hard on himself, and that adds to his anxiety, and then the anxiety made him feel more like he wanted to eat. So it was trying to stop the anxiety or him feeling bad that he wasn't good because he was heavy.
The secret to the success in this situation was getting the right people together.
And when we came together, that's when we had the most success.
So I think it was a matter of completing kind of Team Liam.
So just an example of how we've sort of peppered through the casebook some different kind of resources or different voices, and trying to really show the different voices. And we have them with clinicians as well, and other people that are involved. So thank you for coming. We didn't want to go right till the end, but I'm happy to take any other questions, comments, queries, reactions, as well as my 2 co-hosts as well.
Great job.
Thank you. Okay, that's the reaction we like. Anyone completely horrified by what we've done? Well, that's also, Sean.
I just wondered, do you have any surprises, and would you recommend this for other groups to take on a case?
Oh, it's been a massive job. I have to say that these 2 have done a lot of the heavy lifting. Like, it's got to be a really committed team, not a committed team, but we've pushed this to coordinate with World Obesity Day and OCAS. It's been a hell of a lot of hard work. But we're all really thrilled with the outcome, and we really want to know then, when we get it into the hands of people using it, that will be the key test of whether we've done a good job or not. So we're sort of slightly biting our nails, hoping. We've had a lot of clinical input along the way, so we think it's relevant and applicable, but really looking forward to getting it out there and seeing if we can help in any way or make an impact as well. So, yeah. Tom.
Congratulations to your team.
Thank you.
Really impressive work. I was wondering if there's any thought in terms of the rollout, in terms of connecting with the schools, given that you talked about the bullying and the stigma that happens in the schools.
So, I mean, it's not a stretch to say. I think there could be some companion products that come with it. I mean, this is aimed at healthcare professionals, but you could see how it could be rolled out. So, but it might be some of the takeaways. So maybe it's not an entire casebook, it's some of the takeaways, the do's and don'ts, or the think about this, or resources. So I think for sure we'd like to do like an implementation kind of pathway, but also companion products like for schools, maybe for parents. There are some resources out for parents, and we do actually include them just in case anyone asks healthcare professionals, what can I read? So we've tried to give them some resources as well. But yeah, in the weight stigma and bullying in schools is a key issue. So yeah, for teachers. Yeah. Laurie? So we have had people on the OPBN do this, so the Ontario Pediatric Bariatric Network. So Jill Hamilton has been part of the team who leads that. So as soon as it's launched properly and we can give a link for people to actually visit it, then we will for sure be shouting it from the rooftops, and then we'll encourage you all to do the same. Any other comments, questions?
One more quick question, sorry. It's really amazing work, guys. Congratulations. I'm just curious, you mentioned, and I'm very intrigued, the innovation framework.
Yeah.
That you used to kind of co-create this. Correct me if I'm wrong, guys. Part of your journey along the way was to engage different system voices at different times.
Yeah.
So you have brought together a group of people who have co-created this with you.
Correct.
Where is there an opportunity, or maybe you've already done this, in terms of looping back with them and asking them around in the systems in which they work and live? Is there an opportunity for them to kind of have a conversation around the what next?
Yeah. So comment just said we've engaged so many stakeholders just talking about looping back to them to figure out sort of the next steps. So for sure, is that when the next stage, all of those people that we engage are going to be able to give review it if they wish to, for sure, and tell us how they think it could be used or where they see in their practice it could be used. As well as we had some community stakeholders from the Canadian Obesity Network YYZ chapter as well. So I'm really intrigued as from a patient advocacy point of view, how might this be used? And like Brendan's story is a classic, you know, he's saying about, we actually ask him, what should they be saying to you? What shouldn't they be saying to you? And he's like, you know what, when you say I'm going to be dead by 30 when I'm 10, not so useful. So, you know, so things like that. And he said, you know, what if people talk about in this way? And he gives some really great ideas about, you know, you need to feel confident to say, I don't want to talk about it or whatever. You know, so we're trying to make it as sort of all levels, so from a client and family perspective, as well as sort of up through different levels and clinicians. So I think each will take something different from it, and so phase 2 will be trying to capture all of that for sure, and in the feedback loop. But the innovation model was really important for this work, because traditionally there's not too many KT casebooks out there, but when they are, they tend to be, you know, each chapter is a different service. So there's a pain one, so the pain service in Nova Scotia, the pain service at Sick Kids. So, and they're sort of individual chapters, and everyone writes the same thing, what happened on in their programs. So we're pretty excited that we've managed to do something different. And I was to say, if Shannon Crossman was a key part of facilitating those workshops, using a lot of arts methods and arts techniques as well. So that was kind of neat too. I think she thought we were mad when we proposed the idea to her, but she jumped in, which was fantastic. Okay.
I wanted to add a point to the comment that Sean made earlier about, is this something that we can see that other teams to do, and just how Amy talked about how we engage different stakeholders and brought Shannon on and Laura and myself, and it really speaks to the importance of how you put together your team and the different strengths and energy and passion that people bring, and how you can really work together to co-create such an impactful product. And that's really important when you're building your team for any kind of project, Center for Leadership, a grant, what have you. So just wanted to hit that home, because it really did contribute to the success of our product that we've created. Mm-hmm.
And one of the driving forces was a nurse that I've been working with for years and years, and she was on the team and has unfortunately left Holland Bloorview, but she played a very key role in kind of kicking off this work. So it's kind of, we have to send it to her and see if we've done her proud. So hopefully we have. Okay. Thank you. If there are no more questions, feel free to stay and ask if you want to ask us something. But Thank you for letting us show our baby to you. And stay tuned for the end of November where we will be launching it fully. And please champion it wherever you go and and help us disseminate it. So thanks very much, everyone.